Dr. Pankaj Vej. Due to some personal issues, he's not able to attend in person, but so it's going to be a virtual lecture on Zoom. So please bear with us. And it's my honor to introduce Dr. Vej. Can you put in? I'll go ahead and introduce him while he comes on. There he is. Pankaj is a dear friend. He's an internist. He's a lifestyle medicine specialist. He did his medicine from All India Institute of Medical Science in New Delhi, and then did residence in Detroit, Michigan, in Royal Oak, where I met him long back. He's the director of Lifestyle Medicine Global Alliance and founder of Crack the Wellness Code. And he is also the author of Turbo Metabolism, and he's a TEDx speaker. And he's coming back from last year. He was here as well. And we have asked him to talk on reversing diabetes, going in line with lifestyle medicine. And he has a excellent program at Kaiser Permanente, and we have told him to share something that he can share. And Pankaj, thank you for joining us.
Thank you. Thank you so much, Anup, for the invitation, and thanks for being flexible in letting me present virtually, as my dad got really sick last week, actually, and that was the reason that I'm not able to travel. And I hope we can get through this without any major audio-visual glitches. Are you able to hear me and see me okay so far? Okay, I'll take that as a yes. I can't hear a response. So we'll go ahead and get started, and please stop me if there's any issues. My topic is sweet success, unlocking the secrets of diabetes reversal and prevention. Are we good, Roshni?
Yes,
Okay, good. Perfect. All right. So my learning objectives are really to evaluate the evidence for diabetes reversal and prevention through lifestyle. And really, the most important objective is the second one, to give you practical strategies to help identify and implement effective tools and techniques for coaching people on behavior change, because that's what we want to do. Is we want to empower the individual to take care of themselves, to motivate them, to engage them, and to make these changes so that they can really take charge of their own health and really their own life by doing so. So we'll go ahead and get started. I'm going to go through quickly some of the initial background information, much of which all of you here in the room know. As you know, obesity is now the #1 cause of preventable disease and disability, not just in the United States, but worldwide, and leads to a whole litany of metabolic diseases, the most prominent and well-known of which is type 2 diabetes. 90% of diabetes now is type 2. And if we look at pre-diabetes, which is really the first warning of metabolic disease, that's probably half of the patients that you see every day. And they have all the other things that go with metabolic syndrome, such as high blood pressure, high triglycerides, increase in waist circumference, leading, as we know, all these things lead to cardiovascular disease, strokes. 14 different cancers are directly linked to visceral adipose tissue, sleep apnea, osteoarthritis, polycystic ovary syndrome, infertility, the list goes on and on. The last lecture was on Alzheimer's, and there's even some talk about Alzheimer's being type 3 diabetes and it being related to metabolic dysfunction earlier in life. I didn't mention here metabolic disease associated liver, so MASH. I think there was a lecture on MASH earlier as well. And all of it is related to really what I call the epidemic of diabesity. So by current BMI criteria, which we're reducing to 23, every other person in the US is already obese in the year 2024. So the predictions were 2030, but here guess what, we're ahead of schedule, and that's not good news. So what is the cause of insulin resistance? In a nutshell, what this slide is saying is that insulin resistance and all of these metabolic diseases are the result of lean adipose tissue becoming obese adipose tissue. So that adipose tissue, those fat cells, are no longer able to hold any more energy, and therefore start getting a lot bigger and fluffier and producing inflammatory cytokines, inflammatory markers, things that cause inflammation in the body because of ectopic lipid accumulation, i.e. steatosis. In the liver, we call that hepatic steatosis, which causes liver insulin resistance. In the muscle, we call it ectopic lipid accumulation in the muscle, or essentially causing a lipomyodystrophy. That is the cause of insulin resistance. It is these tissues saying, we're closing the gates. We don't have any more room for more energy to be stored because you're sending us too much energy and not burning it. And we've stored as much as we can store. Now the gates are closed. Please keep out. That's what insulin resistance is on a cellular level. And when that happens, it doesn't matter if you're a famous celebrity like Tom Hanks or a common person. We're all going through the same pathway. It doesn't matter what your heritage is, what part of the world you're from. This is happening all over the world to all of the people that we see, including ourselves. So I want to take a walk down memory lane and really go back a little bit to my days in medical school and residency. I remember very clearly in residency when the UKPDS randomized control trial results came out. And the summary of it was that diabetics have micro and macrovascular complications. This happens over time. 9 years after the diagnosis of diabetes, in this particular study, 29% of people had diabetes-related complications. And these were the ones that we worry about the most are heart attacks and strokes, which are called microvascular. Then we have retinopathy, nephropathy, and neuropathy. So we have macro and microvascular complications that are going to happen over time, and they're directly related to A1C. So let's get the A1C down. That was the gist of it. That led to intensive insulin therapy and the idea of really hitting people hard with drugs to get the A1C down. That was the conclusion. And as an internist, the interpretation for myself and a lot of my colleagues and who are residents was, hey, this is a disease that has no cure. It's chronic, progressive, and often fatal. While the patient lives, the welter of medical complications that sets off can attack every major organ. And this is a one-way street. So this particular paragraph was actually from a headline in the New York Times, but this is what we read in our textbooks as well, that this is a chronic irreversible disease. All we can do is to manage it. Let's give them more and more and more and more medicine to try to keep the A1C down. But you know what? Over time, it's going to go up anyway, and then we'll have all these complications to deal with. That makes our job feel like this. This is the curse of Sisyphus, where he's trying to push a boulder up a rock up a slope, a boulder. And of course, it's a task that's impossible. And he takes one step forward, 3 steps back, and eventually the rock is going to crush him. And that's what made my job feel like, and all of our jobs feel like every day, because we're dealing with a disease that is irreversible, that has no cure. And we felt helpless, and the patient felt helpless too. But that may not be the case. This is actually a good news, bad news story. So do you want to hear it first? And it's just interactive. I would ask the question, who wants to hear the good news? Raise of hands. Who needs to hear the bad news first, so we get that out of the way? A few people raise their hands. And I would say, well, I want to tell you the bad news first. Let's get that out of the way. The bad news is that crash diets always come crashing. Calorie restriction in and of itself, just focusing on calories, doesn't work because it's not sustainable. Nor does willpower, hypnosis, or some other magical so-called therapy does not work. Or there's no supplement that's really going to fix this problem. Liposuction only sucks fat under the skin, so it's not even getting to visceral adipose tissue. The bottom line here is the bad news is that there's no shortcut, there's no quick fix. And the rest of my presentation is a good news story. And I hope you can still hear me okay, because I have a lot of good news for you. The good news is that when we treat the root causes, when we treat the cause of the problem, we can prevent and reverse it. We can prevent and reverse diabetes, obesity, and heart disease when we understand and treat the root causes. So what are the root causes? Really, in a nutshell, it is the way that we're living in our so-called civilized society, where we have really an excess of highly refined, highly palatable foods that are often loaded with refined carbohydrates and fats. They don't have much micronutrients and not much fiber. To top it, we are inactive and stressed and not sleeping. So the so-called civilized environment is not the natural environment in which our ancestors have lived and thrived for millions of years. So lifestyle medicine is an evidence-based approach that looks at the master levers of health, which are what we do with our feet, forks, and fingers: rest, relaxation, and relationships. So forks, what do we do with our forks? We eat. So when we eat a healthful, whole food, plant-based diet, when we move with our feet the way that we are designed to do, with the way our ancestors have done, when we stop using our fingers to smoke and hold glasses of alcohol, i.e. avoiding risky substances, when we learn how to rest, this is developing strategies for managing stress, when we learn how to relax by improving our sleep quality, so stress and sleep are related, and when we form and maintain relationships, we can reverse disease. The biggest and strongest pillar of this is food, because food is medicine. Food is not entertainment. Food is energy plus intelligence coming from the earth to us to nurture and nourish us. And I would argue to say that of the 6 pillars, 80% is food. The food is the one that has the highest impact. And the other pillars we'll get to momentarily. So if you go back to the evidence, there actually is some evidence that this works. But it's funny how, as physicians, we're geared towards looking at, or maybe we're already programmed to look at drugs, pharmaceuticals, and surgery as the only treatment that we can offer. So when I started learning about lifestyle medicine, I actually went back to my residency days again, and I read back about the diabetes prevention program, the DPP, in which they enrolled 3,548 subjects with pre-diabetes, which at that time they used to call glucose intolerance, or IGT, impaired glucose tolerance. And they randomized them to either metformin 850 BID or a lifestyle modification program. And the third group was placebo, which was just routine care, whatever they were doing. The lifestyle program was motivational counseling with a goal of 7% weight loss, a step 1 NCEP diet, National Cholesterol Education Program is what they used to call it at the time, and physical activity of 150 minutes a week. So not super intense, but it was something. And of course, they were comparing that to metformin, 850 BID, and the results showed what they showed, but the conclusion that I made, and most of the people that I spoke to made, was that metformin is the closest thing we have to a magic pill for diabetes. Again, we were with the eye see what the mind is looking for. But really, this was the data. The placebo group, of course, the cumulative incidence of diabetes kept on increasing as time passed. From pre-diabetes, they went to diabetes. In the metformin group, there was some reduction, but the lifestyle group was actually twice as effective. So metformin reduced the incidence of pre-diabetes going into diabetes by 31% when compared with placebo. But the part that I ignored, and most of the people that I knew at the time ignored, was that the lifestyle intervention reduced the incidence by twice as much, by 58%. It was twice as effective, and we completely ignored that. And we started saying, okay, metformin is now indicated for pre-diabetes. Metformin is a wonder drug. Everybody should be on metformin. It should be in the drinking water supply. And it wasn't just the DPP, this was repeated in several studies. The ducking study, this was done in Asia, showed intensive lifestyle intervention resulting in a 39% reduction. And they did a 30-year follow-up. This was published in The Lancet in 2019. The Finnish diabetes prevention study, very similar results. This was in Lancet 2009. Intensive lifestyle intervention resulted in a 34% reduction in developing diabetes at 10 years of follow-up. And you can see the corresponding effects on cardiovascular deaths, cardiovascular events, composite microvascular disease, and all-cause mortality. Everything correlated the same way. Which led to now the AACC recommendations 2021 talks about lifestyle front and center, and nutrition is number one. And they talk about avoiding trans fats, limiting saturated fats, and done with structural counseling and meal replacement. Technological aids like apps and such can help. And you can see plant-based diet right up there. Highly polyunsaturated and monounsaturated fatty acids. And this can happen with eating a plant-based diet and avoiding animal products. Physical activity of 150 minutes comes up again, which is moderate exertion, i.e. walking and stair climbing. Again, wearable technologies can help here. I think the Apple Watch or the Fitbit are fantastic aids in this, in helping people track. And you can see the other pillars, right? What I talked about in lifestyle medicine, there's sleep, 6 to 8 hours a night, educating about basic sleep hygiene, behavior support with community engagement, and we talked about avoiding risky substances. Here's alcohol, moderation. I would say no amount of alcohol is healthy. So if you're looking at alcohol as a health drink, it's just not there. The only health drink is water, and no tobacco products. I think this is a no-brainer. Most people know this. Physicians definitely know this. And in spite of that, if you look across the US, about 18% to 20% of our population still consuming nicotine, right? So alcohol, nicotine, and caffeine are the three most consumed chemical addictive substances, not counting cannabis, worldwide. So, will diabetes drugs prevent complication and reverse my diabetes? Will drugs halt or reverse disease progression? Well, you know the answer now. Diabetes medications can help glycemic control and therefore reduce the risk of complications, but they do not prevent the progressive beta cell failure or reverse the progression of diabetes. And lifestyle medicine is superior to metformin. The DPP showed this many years ago. We ignored it. It's twice as good. Let's get back to that. Let's get back to lifestyle because it's twice as good. And if you're going to read one book this year, I would say don't read my book, Turbo Metabolism, which Anoop mentioned. Read Roy Taylor's book called Life Without Diabetes, a definitive guide to understanding and reversing type 2 diabetes. And this summarizes very nicely all the evidence behind reversal of type 2 diabetes. I don't want to get into a debate here about whether it's really reversal or not, because I think a better would be remission. We can put it into remission, like a cancer in remission. It might come back if you don't do what you're supposed to do. But we can definitely put it into remission and have a life without diabetes. And diabetes is a surrogate for a lot of different metabolic diseases. So the other pillars, we talked about feet, forks, and fingers, right? So what do we do with our feet? We walk with our feet, and walking is great. I always tell my patients in my programs at Kaiser Permanente that walking 10,000 steps is getting your foot in the door. You really want to build up to getting some resistance exercise because that positively affects diabetes reversal and improves metabolic disease. Because these large muscles can act as a sponge, I tell my patients, muscles going to act like a sponge to suck up that sugar and burn it off. And the reason that it's accumulating is that you don't have, the activity doesn't match up with the intake. So resistance exercises can be done with body weight. You can see these happy people doing push-ups, pull-ups, lunges, squats, and planks. None of this requires any equipment or gym membership. And of course, if you talk to Anoop, he's going to say that you can do Surya Namaskars. You can do 108 Surya Namaskars, which is an age-old tradition of what the fancy word for that is now high intensity interval training. So you're going from planks to squats to push-ups to lunges in multiple cycles, getting your heart rate up. And again, you can do that in your bedroom, you can do it outside in the backyard or your local park, or even on the floor in your office between patients. You don't need to go to a gym to do this. Again, we could have a whole lecture on sleep, and we have had lectures on sleep, but I'm just going to touch on it in the idea that we know this from our own experience too. When we're sleep deprived, when we're on call in the hospital overnight, we have our appetite sensors change and our food choices change too. We're consuming a lot more cookies and chips when we're sleep deprived. And in the lab, you can actually induce insulin resistance by sleep depriving the subjects for as little as 3 days. And what was really interesting was that melatonin receptors were actually found in the pancreas. Melatonin is related to sleep, as everybody knows. So why would there be melatonin receptors on the pancreas if there wasn't some connection between pancreatic function and sleep? Well, we know it on a cellular level, and we see it from our own experience, and we've seen it in trials as well. So sleep is very, very important. Stress, and again, not to spend a whole lot of time on this, Anup is going to talk about his ideas of the power of infinity, but really connecting with whatever higher power you define in your own mind has powerful effects in calming down those inflammatory cytokines in the body. And again, we see this in our own experience. One common example is stress-induced hyperglycemia, right? Someone could have impaired glucose tolerance or prediabetes, or even be completely healthy, and you put them in the hospital, put them under some stress, give them some steroids, and their blood sugars go up. So if we can manage that stress, all the manifestations of this metabolic disease, particularly cardiovascular, which we're the most concerned about, have a reduced incidence. And then again, this has now been shown in multiple trials. There were over 1,000 trials on yogic sciences, on the effect of yoga, pranayama, meditation on reduction in cardiovascular disease. But I think this is where the most important part of my presentation is. It's about getting people to change behavior, right? It's one thing to know what you need to do, but getting yourself or your child, your family member, your patient to do it is a whole another story. So what is motivation or lack of motivation, and how do we get somebody motivated to make that change? Even when if they agree with you, in theory, it sounds good. How do we get them to make that change? Well, ambivalence is normal, right? It's normal for someone to be ambivalent, even when they know the benefit of something. But for change to be sustainable, we need them to enter, continue, and adhere to that change strategy. And that starts with their readiness to change. So again, I can't see you, but I'm just going to ask the question, and I want you to look around to see how many people are familiar with the 5A model of behavior change. So the 5A model is to ask permission first. Ask, advise, assess, assist, and arrange. So we'll talk about that in a second, but I think that's the really key thing, is to get someone ready, willing, and able to change, right? Willingness means they understand the importance. Able means that they're confident that they can make that change. And readiness, well, readiness is a matter of priorities, right? You could be willing and able, but just not ready. I'm not ready right now, but I'll think about this in 6 months. So how do we assess readiness? We assess, and that was the third A, the assess. So you ask permission. Do I have your permission to talk about your weight or to talk about your smoking habit? If they say, no, you don't have my permission, then the conversation's over for that visit. We could come back to it another time. But you ask and they say yes, then you're going to say, well, I advise you to quit smoking. Okay. And you get a yes, you get an affirmative on that. You say, the person says, okay, they're nodding their head. Now you have to assess their readiness. That's the assess, that's the third A. how important is it for you right now to quit smoking? And they said 3. Well, why did you say 3 and not 0? And they said, well, it makes my teeth stain and my wife doesn't like it and my breath doesn't sound good and I start coughing. Okay. So you said a 3. What would it take to get you from 3 to 6? Right? We're assessing readiness from 0 to 10. And the most common place where we see this is if you go to a car dealer, they say, okay, if you decided to change, are you ready to buy a new car? You're at a 6. When do you think you might do it? If you decided to make the change, are you in the market for a new car next week, next month, or next year? And what can I do to make you buy that car from me today, obviously? So I'm not saying that we should be salespeople, but it is a little bit of communication technique involved here. And this is the most critical piece. So this is a motivational interviewing. That's what this is. It's a directive, patient-centered counseling style for eliciting behavior change by helping the patient explore and resolve their own ambivalence. Because the answer has to come from them. I can't ask and then advise you to do something and expect that magically it's going to happen. And the most critical piece is that you need to be motivated, and then I can assist you and arrange to help make that happen. But the readiness to change has to come. The drive has to come from the individual. And this is done with empathy. I'm not sure if this is going to show, but we can try. This is a very short clip. Let me know if this doesn't work.
So what is empathy and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, I'm down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. I had it, yeah. And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
Beautiful. Thank you. And I'm told you could hear it, so great. And I'm going to try to move a little faster to get us caught up on time. I'm almost done, actually. So let's see here. Let's get to the next one. Oops. So empathy requires skillful reflective listening and acceptance, because when you talk to the patient, they might not be ready today, and it's okay to meet them where they are and take a few steps. So it's not about my way or the highway, it's about meeting you where you are, and let's see if we can take a few steps forward to help you achieve your goals. And if you're not ready this time, then I'll see you back in 3 months and we'll talk about it again. We figure out if there's a perceived discrepancy between present behavior and important personal goals, and then tie the behavior to the goals, thus improving their self-efficacy and empowering the individual to take charge of their own health and their own life destiny. Again, I'm not going to spend too much time on this, but the idea is to highlight the disadvantages of the status quo and the advantages of the change, so that the person becomes motivated to make that change on their own. That's the key. It's coming from them. It's not coming from you. Something that can help with that is changing the environment. You change their physical environment, their emotional environment, and their social environment. So physical environment would be, what do you have in your refrigerator? What do you have in your kitchen pantry? Let's take out the trash. Let's replace it with good things, so that the right choice becomes more of the automatic choice. This does not require motivation. This is all automated now. The social environment is the people you hang out with. If they're like-minded, have similar values, then it becomes easier to make that change. And the emotional environment is up here in your head. If you're thinking, oh, poor me, I'm a victim, I can't eat that food, I can't smoke, I can't go drinking with my friends, you're not going to be happy. But if you change the emotional environment and say, this is empowering, I'm doing something that's going to improve my quality of life, that's a completely different mindset. And that's the power of social connection, because social connection is the strongest determinant of health and happiness. This was seen in the Harvard longevity study, which you can look at the TED Talk by Dr. Waldinger on this, which the essence of which was that the quality and number of social connections by age 50 is a stronger determinant of your longevity than anything else. Socioeconomic status, exercise habits, smoking, alcohol, food, any of that is overpowered by social connections, because connection is a strongest determinant of health. Man is a social animal. And this goes back to the motivational interviewing piece. You start and end with why, right? We often, when I ask people why they're in my programs, they tell me it's for quality of life. I want to have a longer life. I want to be around. So if they say, I want to lower A1C and lose some weight, I always ask them why 5 times, because the real reason is something else. They want to be around, to love, to share more love, to be loved, to love others, to their grandkids, their children, their spouse, their friends, to have beautiful experiences, go on adventures, go climb to Everest Base Camp, go check out some place that you would not otherwise be able to do if you didn't have good health, to learn, to be a lifelong learner, to grow and contribute. These are certainly my life goals. What's your purpose? And just a little bit about my program. I call it HALT, Health Achieved Through Lifestyle Transformation. Just to give you a very brief overview of it, we have consistently achieved an A1C reduction on average of 1.8%. The highest number is really high. We've had as much as 6% reduction, and this is in a 6-month period. But 1.8% reduction is better than any of the latest and greatest diabetes drugs that are out there. And you can look this up. They're about 1.6. On average, we have about an 11-point weight loss. We're not a weight loss program. Weight loss is a byproduct. And we have, on average, about a 2.2-inch reduction in waist circumference. And this matters because when you lower A1C by 1%, you lower healthcare costs by $3,000 per year. So if you took 100 patients and did this, you're lowering healthcare costs in your system, if you work in a healthcare system that cares about these numbers, by $500,000. And it doesn't cost $500,000 to run these programs. So let's face it, fit is the new rich. It doesn't matter what your net worth is if you're not fit and healthy to be able to enjoy the wealth that you've accumulated. Some people will try get fit quick schemes. Some people will just fake it. Some will blame destiny. Oh, this is my genes. This is how it's meant to be. There's nothing I can do. But lifestyle medicine is about empowering the individual to take charge of their health, to give the power back to them, because even if you're walking around with a loaded gun in terms of your genes, it's up to you and the health behaviors, the life behaviors that you incorporate are going to determine whether you pull that trigger or you have a healthy and happy and long life. Thank you for your attention.
Now, we are open for questions. I have a question before others ask questions. Is there any research on owning dogs? Talking about connections.
Research on owning dogs, yeah. Pet therapy is there. There is research on owning dogs, and when you spend time with the dog, you actually physiologically have the same response. The oxytocin release, the serotonin release, interestingly, in both the dog and the human, is very similar and goes in parallel. And those who own dogs know this, that they help you relax and calm down even after having a bad day. And it's about sharing that love. Absolutely, it's been shown to reduce the cortisol, release oxytocin, release serotonin, lower your blood pressure, and is a great way in this world of loneliness where there aren't enough people, at least in Western societies, for people to interact with. Owning a dog is a good idea.
Thank you, Pankaj. Any other questions? I know we are behind, but we have time for one or two questions. Going one, going two. Okay, if there are no questions, I have few announcements before. You have a question? We do have a question. We are fixing the mic. Okay. Okay, hold on.
Hello. Thank you, Dr. Pankaj, Rich, for that wonderful talk. My question was, I see a lot of Asian Indian population with high triglycerides. I'm a pediatrician, but even in the younger kids, I see this pattern. And then I do see them having the pre-diabetic, they are pre-diabetic and then they're going into the, high hypoglycemia. So is there anything specific that you would recommend for them? Is it just, they are eating healthy, they are kids who are exercising on a regular basis in school. So I'm still kind of wondering what is the reason? Is it just genetics and we just leave it at that, or?
So your question is about, I can repeat the question if they can hear me. I think this is a pediatrician, and the question was about high triglycerides and whether that's a concern or should be left alone, right?
Yeah, that's a question.
Yeah. So as we know, high triglycerides is one of the 5 things in metabolic syndrome. So, and we also know that metabolic syndrome is showing up earlier and earlier. When we were learning about it in medical school, we always learned that the type of diabetes that kids have is type 1, and the type of diabetes that happens as adults is type 2, whereas now we're seeing type 2 as the predominant one in children as well. And that's because of, again, lifestyle factors, probably that start even in utero. So these kids are getting exposed to processed foods and junk foods and a hypercaloric environment from their mom, and then they're born into that environment and they're getting it. It's interesting, we talked about pets earlier. You even see pets having the same metabolic diseases as their owners. So animals don't get diabetes and obesity when they're out in the wild, but when they're in human domestication, they get those same diseases. So I don't think we should be ignoring high triglyceride in kids. I think we should be treating it as the early onset of metabolic disease with lifestyle. And it should be starting super early. It should be starting during pediatric time so that we can prevent them from getting type 2 diabetes, cardiovascular disease, cancer, all the things that we named later in life. And because the damage is done, the damage has already begun even before the age of 18. Autopsies have shown, plaques in coronary arteries in veterans that came back from Vietnam who were teenage, in their late teens, 19, 18, 19, 20, they already had plaques. So the process has begun. It's environmental, it's also exposure in utero. And some of it could be genetic because we're passing on those traits. But absolutely, we need to work on them with lifestyle early on. And there's no reason to wait until they're not with their pediatrician. I think pediatricians need to know about lifestyle medicine too. And a lot of our leaders in lifestyle medicine worldwide are pediatricians because of the same reason.
Thank you, Pankaj. I think that was the last question. Thanks for joining.